with what we were talking about earlier and the unfortunate politicization of science. And please, talk to the audience about your views of that and how do we get beyond that to a point where science is non-political and biomedical research benefits everyone.
I mean, I thank you for that question. You heard I started with a justification of the Maha movement. And if you noticed, I said it's a political movement, but it's not inherently political. Like, it's inherently a fundamentally apolitical movement. It's just a desire for a better life, and for the desire for science to be translated to a better life for people. That's not political. I can tell you, the last 9 months as I've been NIH director has been dismaying to see, frankly, I'll just be blunt. I've seen politicization of the agency from all parts of the spectrum, right? Like, budget cuts because of sort of this desire for the short-sighted desire to cut our budgets because the nation is trillions of dollars in debt. That's one side. Distrust about the NIH as a holdover from the pandemic, and then on the other side, to desire to paint members of the administration as anti-science. All of that, I think, hurts science. The thing as we as scientists should be saying loudly to the public whenever we engage now with the public, and I'm going to try to do this myself more, is that science is really the answer to those problems, right? It's how we solve the problem of America being so flatlining life expectancy. Science is the answer to the problem of why we have a $40 trillion debt, because our population is unhealthy. We spend tremendous amounts of money on Medicare and Medicaid. All of the fights over the ACA, Affordable Care Act, is because we haven't solved the health problems of the country. The answer to your question is, for science, we scientists should be talking to the public, giving them the real hope that the advances in science offer. That's how we get out of this politicization.
So I'm going to ask some questions that this group put together, and I'm just going to start with the first question. What emerging health threats or unmet needs are top of mind for NIH to which the public may not be paying enough attention?
I listed some of them that for instance, how many people knew that we flatlined in life expectancy? I'm curious. Is it because you heard me say it? I was surprised. I've been surprised how few people knew that. It should have been, like, alarm bell should have been ringing for a decade over this. That is the top line thing that I want to address. But that encompasses a ton of things, right? The chronic disease crisis means the Alzheimer's crisis, right? It means solving Parkinson's. It means solving ALS. It means and for kids, the autism, the rising prevalence of autism. It means solving, figuring out how to make the advances that we have had in biomedicine cheaper and more accessible and available. So we have now a miraculous cure for sickle cell anemia, but it costs like $2.5 million to get access to it, right? We need to do science to make it more cheap and more affordable for everybody, so that we will never have to worry, a child and a parent will never have to worry about, pain crisis from sickle cell anemia again, right? We have that in our capacity. That's what's on top of mind for me.
One of the great interests that we have at Mount Sinai is health research and health disparities. You may know Mount Sinai is sandwiched between one of the richest and poorest zip codes in the United States, and many of our faculty are interested in finding ways to make sure that every person who walks through our doors gets the best possible care. Tell us about your thoughts about NIH's role in that effort.
Yeah, so this is another thing where it's been painful to watch. Because at the NIH, we've removed our commitment to DEI. What we haven't done is we've not removed our commitment to advancing the health of minorities. Those are two distinct things in my mind, right? So the NIH's mission is to do research that advances the health and longevity of people, meaning all people. And minority, I also am guilty of having done lots of health disparities research before. And I think it's important, that kind of research, to identify health needs of people. What also a lot of health disparities research that was frankly political, that had no hope of translating over into better health for minority populations. You can see it in the numbers, right? The health of minority populations over the past 15 years has gotten, it certainly hasn't improved. They flatlined along with the rest of us. We've all flatlined together. The chronic disease crisis is worse. What has that research and investment in DEI by the NIH done for minority populations? What it's done is it's made our portfolio of research look like it's political, like we're aiming at a political aim rather than something that's universal. And that universal aim, improving the health of everybody, is what I'm instructed to do. So like if you want to do work on health disparities, I'd welcome your proposals. The key thing is, first, make sure it's really scientific, that you're like specific about exactly what you're doing, that you're proposing testable hypotheses that are in principle falsifiable. Second, it's actionable. You are not just saying, oh, there's a prevalence difference that everyone already knows, but that you're trying to figure out how to improve the health of minority populations with some interventions that actually will work, right? So if you have a proposal to reduce the price of I keep beating this example, but there's lots of other examples I could use of care for sickle cell anemia, to reduce the price of care for that with scientific advances, I welcome it, because that will improve the health of minority populations. And then third, it has to be in scope of the NIH, right? So, there's a lot of things you could potentially think about addressing, but there has to be things that are related to health and healthcare that are inside the mission of the NIH. Those three things, if you could send a proposal on aiming at improving the health of minority populations, I really, really welcome it, because you'll see a lot of success at the NIH with that.
That's great to hear.
I'm going to ask another question from the group. Many essential questions in physiology and disease, as well as the in vivo evaluation of therapies, cannot yet be addressed without whole organism models. Can you clarify the NIH's position on the future use of preclinical animal models?
Sure. Okay, so this is not, it wasn't my field, so this is something I've learned. This is one of the few fun things about my job, is I've got to meet some amazing scientists. One of the first things people I got to meet were people at the NIH who've been working for a decade on organoids, right? And what they showed me is tremendous advances in these organoids that even a decade ago, again, would have seemed like magic, where you can, who in the room uses organoids in their research? So, you all know what I'm talking about, right? A lot of things that we once required animal models for could in principle be replaced by organoids. Now, there's still some real needs in the field, right? So standardization, replication of all the results, a whole bunch of things that are needed in the field. And so I decided I was going to just invest in it. Right, so we have a new standard organoid modeling center that is going to help with standardization of practices in the field. We're going to have a new center that's going to sort of make investments in development of these new technologies. There are still, of course, questions that organoids can't handle. And we have to invest, so like, for instance, I don't think there's correct me if I'm wrong, and someone in the room is probably already working on this, but like if you're studying hemophilia, you can't do it with organoids. So the policy is going to be, if you're proposing to study a topic and you want to use animals, you have to justify that there isn't an alternative available that can do it better, that the model you're using actually does translate over into knowledge of human health, because that's in scope for us. And so you have to do that. So we're sort of not saying don't use them, but we're saying think about it. Like, are there better alternatives available that will do better science, will translate over better for humans?
One of the questions that was asked is about the modular budget, getting into the real nitty-gritty of NIH. And I think the $250,000 maximum of modular budgets was instituted maybe like almost 30 years ago. And the question is, that really did reduce the administrative burden on universities, I think on NIH as well. Is there talk about changing that?
And I think it's now only like 10, 15, 20% of our portfolio uses modular budgets. Once upon a time, it was a lot more. I think that $250,000 level is probably too low for a lot of the projects, which is probably why that's. I've been thinking about how to restructure that, but I shouldn't get ahead of myself. There's a lot of we're going to do listings, just like we're doing with biosafety. we're gonna do listening sessions to try to see like how to address that, because there are real trade-offs, right? So if I raise the total amount of a modular budget possible, then big labs will get funding more easily, leaving less for early career scientists who don't necessarily need such a large budget, potentially. And so like structuring how we deal with modular budgets should be part of a broader portfolio of reforms to the caps. I'll just preview one idea. There's a mechanism we have that I want to see potentially more expanded, right? So like I mentioned earlier about grants where you have aim 1 is, if it works, then you can do aims 2 and 3 and the world will get better. But if aim 1 fails, you can't do aims 2 and 3. And almost always those grants get bad scores, you can't get funding on it. But what if we had a structure where if you have a proposal that's scored like that, you have a funding structure where you get 2 years of funding. At the end of 2 years, there's an administrative review, and then you get the last 3 years of funding if aim 1 worked out, right? I'm thinking about structures like that. I want to think very creatively, but I want the scientific community to tell me what they see also. It's been fun to like interact on a whole bunch of topics where we can get feedback on like what we pay for open access, for your public access fees, for instance. I mean, stuff like that where we want the feedback of the scientific community. Before we do anything with those caps, I'm going to have an open listening session for the scientific community.
We'll just take an extra 5 minutes. I know we're right at 5 o'clock now, but we'll go another 5 minutes for questions before having a reception.
This is a good follow-up, and this is a question that was asked by many people here. NIH awarded significantly more grants with multi-year payments in 2025, which reduced the total number of grants, obviously. Was this a temporary change, or how do you see, will they do this in the future?
There was a ton of pressure from like the budget folks to increase the number of multi-year funding. The way multi-year funding works, a 5-year grant, instead of having obligations in year 2, 3, and 4 for future budgets, you spend all the money this year, right? And so the transition in the long run, it doesn't matter, because if you have all the grants that are multi-year funded, you end up in equilibrium with the same number of grants. But in the transition from non-multi-year funded upfront funding to multi-year fund, you can get some disruption. The typical number of grants, it's about 15 to 20% of our portfolio is usually upfront funded. There are scientific reasons to do that, right? So if you have a big piece of equipment, you want to be upfront funded because you can then buy the big piece of equipment and still do the work in the first year, right? So you don't like spend it. So there may be scientific reasons for why you do upfront funding. This past year, upfront funding is about 39% of the portfolio, up from like 15% 2 years ago. What I told the institutes was, when you make these decisions about upfront funding, you have to do it for scientific reasons, right? So we found a lot of grants where upfront funding made scientific sense, the equipment being one example, or shorter grants where it's 2 years long, and it really does helpful to like know you're gonna have that second year funding without, if there's budget uncertainty, things like that. I think if I were ordered to move to 100% upfront funding immediately, it would be very disruptive. I don't think the disruption is too much last year because I ordered it to be scientifically based. I think we're sort of hitting the low margin for that now. So we'll see. There's not a ton of support in the House or the Senate for more upfront funding.
And I do want to acknowledge many of us in the room here were really sitting on pins and needles to see whether NIH would be able to spend the 2025 allocation it received from Congress, and you did, so thank you for that.
Yeah, that was not the challenge I thought I would have as coming into the administration, but that is a testament to the reviewers that reviewed the grants, to the staff of the NIH. They worked hard all through the summer to identify excellent scientific projects. We spent all of the 2025 money on amazing science that's going to come out. Those investments are going to pay off over decades.
Let's make this the last question. Several audience members asked about AI and how AI will transform pretty much every aspect of biomedical research in healthcare. I mean, what are your thoughts now taking the reins of NIH?
I mean, I think those are tremendous opportunities in AI. I don't want to be an AI booster. I want to approach this scientifically, right? So like there are real scientific questions, right? So you have protein folding, right? That's not a solved problem despite the huge advances with AI. We put a lot of money into advances in AI for protein folding because it could potentially have big impacts on drug discovery. But it's not good at like proteins that can fold at multiple equilibrium folds, right? It's not good at that right now. So like I want to invest in that. And there's a whole host of like scientists that are just absolutely passionate about that at the NIH, and I know extramurally. On clinical uses of AI, there are real research questions, right? So you have an AI that can like interpret CT scans or something, right? How good does it do that? Can it do that at a level where unsupervised it can replace a radiologist? I think it's still quite far from that. What level of safety do you require? Right, so like those of you who are cardiologists, back in the 90s, you were like not a cardiologist, but I was like forced to learn how to read an EKG. There was a book, EKG PDQ. Fantastic little book. I don't remember how to do it, but like all my cardiologist friends can. Now there are machines that can read, and what my friends who are cardiologists tell me is the machines are really, really good at it. They're not perfect, they still have to be reviewed, but they're still really quite good at it. What's the right level so that we can use it in clinical ways? How much human intervention should there be? These are all research questions, and I'm going to invest in answering them, because otherwise, because the transformation of healthcare by AI requires answers to those research questions.
Fantastic. Dr. Bhattacharya, thank you so much for joining us today.
Sorry I didn't have time to, I spoke too much, I should have answered more questions, but.
We're actually going to have a reception, and if it's okay with you, people may find you for additional questions. Thank you, everyone.